this actual presentation, it's not entirely my presentation. This presentation has been given in Edinburgh Symposium, Trauma Symposium, by Mr. Alastair Murray, and I have to give him the credit. I'm just sharing with you guys about what is up to date. This is the presentation this year, in last August, last month actually. Okay, so to start with, so femoral fracture in children, it can be addressed by different ways. It can be addressed non-operatively, like with a public harness, with the balance traction, with spica. Can be also addressed surgically, as we can see over here. We have nails, we have rigid nails, flexible nails, and please don't say tense. Just say either intramedullary flexible nails or intramedullary rigid nails. And we have plates, of course, and we have external fixators. So as you can see, we have many different modalities, and there is no right and wrong. So in pediatric, usually, you need to use your common sense. You have the tools, and how you're gonna use it in the best way for the best outcome. So just quick epidemiology. It is 1 in 5,000 kids, or maybe less. It depends. You can think about how many you see in your hospital. Overall, it is 2% of kids fractures. It is more common in male, and it has bimodal age distribution. So it is more in toddlers, and then it goes down, and then it becomes more around 10 years or so when a teenager kicks in. The non-accidental injury is pass and fail. So if any kids under 1 year old, actually under 3 years old, you should think about it, but specifically under 1 year old, it is unforgivable not to mention it. So if you saw a femoral fracture, a humeral fracture, you have to say it. Humerus is the most common, and femoral fracture is the second most common. If a child came with a minor trauma, with a fracture of his femur, what we should think about, other than non-accidental injury, it is pathological fracture. So we need to examine or investigate more, and maybe to liaise with the pediatrician about this. Maybe there is a metabolic or genetic disorder in this child. So quickly, we'll go through the age groups, and this is what you need to know. You don't need to know anything else. It is direct, it is a simple and well-known question. So again, less than 2 years old, then I would think non-accidental injury. Again, don't forget. And then if the child is still very young, or maybe up to 6 months, I'll use public harness. If it is more than this, I can use spica, and this can be early or delayed. When I will, it is, of course, it is the preference, but the recommendation, the surgeon preference, I mean, but the recommendation is if there is more than 2 to 3 centimeter overlapping, then it is advisable to get traction first and then put your spica. If it is just less than this, you can put the spica directly. Why the 2-3 centimeter? Because we are expecting at this age group that will be an overgrowth anyway of 2 to 3 centimeter. So this will be compensated for, but we have to always warn or advise the parents about this shortening at the beginning, and then this will be compensated for. And in case it's less than 2-3 centimeter, we advise them on the other side that there will be about, there is overgrowth, but this will be equalized while the child is growing on. And of course, at the end, the traction or the balance traction, Holmes-Bryant's traction. Okay. The next, it is if it is a little bit older, 2 to 5 years. Okay. So this will take out of the equation the Pavlik harness. So we have the spica and we have the balanced traction. So balanced traction, then spica, or immediate spica. And usually 3 to 5 weeks duration are enough. People have different preference in applying the spica. As we said, one of them is it early or after some traction, and the other preference, should we do 1.5 or should we do both? But the most important is just to try to bend the knee a little bit so they can the parent can carry the child, and don't forget about the hygiene in the perineum. So these are some examples over here. So we can see if on the right side there was a fracture and it's well healed, it's well, the remodeling process took place, and we can see on the other side there's another one with traction. So the first one is just directly they applied the plaster. The second one, they put a traction for a week or so, and then they applied their plaster or hip spike. So next, we are coming now to more challenging area. So if it's 6 to 12 years old, so is it traction? Put traction and spica. The child is starting to get a little bit heavier. The weight is increasing, and that will put him at risk of skin problems. So there's a 10% skin problems, and there is 7% malunion, including excess shortening, as per Tischerman paper in 2018. Okay, should we think about surgery? What is the best surgery? Our options over here will be either flexible nailing, plating, and X-fix. If you noticed, we didn't mention over here the solid nailing, because this child is still growing. We are concerned about the blood supply, and we don't want to interfere either with growth or the developing skeleton, if I would put it that way. So flexible nailing, there are some tricks about it, and there are some drawbacks. So it needs some considerations, it needs some experience, but generally speaking, it depends on 3-point fixation. So you go from one side to the cortex to the other cortex, and the nails should be crossing, filling at least 2/3 of the medullary diameter, and the best is to get this crossing at the site of the fracture. So is it easy? Not many people find it easy. Personally, I find it very easy, and it's a very, very good operation, but I know that many people, they have tried to avoid it. If you put some results, we will have some 25% of skin irritation, which is a very, very high risk, at like 1 in 4. 10% you need to open, but usually it is a very small mini open reduction, and this you can actually just do it, reduce it, and then you bring the nail at the fracture site, and then you just reduce the fracture and pass the nail in. There will be 3% wound infection like anything else, 10% limb length discrepancy more than 1 centimeter, and 10% malunion if you are putting your nail with that will cause distraction at the fracture site, which is something strange to happen in children age group. But this is more common, of course, as you may know, with the mini open reduction. Is it always work? Not always. There are some problems. If it is comminuted, if it is very high, if the child has high BMI, or if they are not compliant with non-weight bearing or partial weight bearing instructions. So it can happen like this, but as we can see, still it healed. We can see good callus formation, and hopefully this will remodel, but it can be worse than this. Again, be careful about where the fracture is. The fracture is the distal femur or proximal femur. The medulla is wide, and the nail cannot really control it. Flexible nails, as I told you before, it is the best is to get the crossing at the fracture site, so you can have these hoop stresses. But if it is that low, you cannot. Although I would say the best indication for the nail is mid-shaft and transverse fracture. So you need to think when you are planning to do flexible nailing. So you need to select your patient carefully. You need to have some experience because there are many small tricks, although it is easy, but there are many small tricks even as a solid nailing in adults. It is, some people find it very difficult, some people find it it is their favorite. So type of fracture, is it comminuted, it is transverse, it is it long oblique, is butterfly. The nail size is the best way to get the diameter on the lateral x-ray, and then you put if the diameter, say I would say if it's 3 centimeter, then put 10 millimeter nail, 2 of them, so that's 2/3. If it is 1 centimeter, then you will use 3 millimeter and 3 millimeter, or 4 millimeter and 4 millimeter. 3 millimeter and 3 millimeter actually will not be enough. We said at least 2/3, so it will be 4. And the best is to be the same diameter, both nails. Length of the bone, make sure that the bone is not longer than your flexible nail, although this is not common. You'll need a fracture table, but it depends. Some people don't do, some people do. And finally, the weight of the patient. The recommendation is the patient should be less than 50 kilograms. And I would say put your upper limit is 45 kilograms. So 45 to 50 kilograms is the upper limit to use a flexible nail. Next is plating, the next option. So in plating, it is always, this is what we know. This is what we learned at the beginning of our training. We all do plating. So this is a valid option, but in children is a little bit tricky. Should we, it is a scar, it is a violation of the muscles. Should we remove it or should we not? A lot of these, but sometimes we have to use it, unfortunately. So it is the best is submuscular bridging locking plates, and this can be done under fluoroscopy. And this, the best indication for plating when you cannot nail. So either flexible nailing or rigid nailing, you cannot nail for some reasons, then it is the best to use plating. Usually multiple injuries, sometimes you need something quick, something will not put the patient on under a lot of stresses on their system, especially the lungs. So multiple injuries, using plate can be the solution. Or if there is compliance issues against nails, especially flexible nails, or costs. So the child has maybe some mental problems, the parents are not reliable enough, so you can always use plate and just go and sleep. So still we have complication, 4% periplate fracture as per this paper, and overgrowth may be a problem with this. And no problem, there are problems, like if there is non-union, if there's too much stripping, or if there is metabolic disorders, then this can happen. So again, be careful. X-fix, last resort, fast, soft tissue injury. If there is soft tissue injury, open fracture, polytrauma, all this, so this is the best solution at the beginning, at least, even in the adult. Put your X-fix, stabilize the patient, and then decide what you're going to do. It is, that's the rule of span, scan, and plan. But they found that there is a very high refracture rate, up to 10 to 20%, and there is 75% pin infection. So this is very, very high. So think carefully before you decide on X-fix, and has to be justified, otherwise we will be in trouble. Now, a very debatable issue, locked femoral nailing. So all of the issue is AVN, and there is a 5% risk as per studies. And in the last postnet, they reported that they got only 14 cases in 1,600 nails. If you reach this stage, you can be asked easily about the blood supply of the femoral head in children. So this is a must know, unforgivable question if you don't know it. Some questions in this exam, they know it is difficult, they know it's not basic, and they can forgive you for it. But this question is really an important one, and you can fail if you didn't answer it, or you are not straightforward with it. So there are some studies about the relation between the AVN risk and the entry point. So McNeil, he published in 2011, and they found that piriformis fossa entry point is 2% risk, tip of the greater trochanter 1.4%, but the lateral entry is 0%. So it's very clear message that always use the lateral entry nailing for in pediatric age group. And even now, to more or less, we are using in adults, but in pediatric we have to. These are more studies. If you are aiming for 8, you can always code these. So either you can say there are 3. Remember Miller, this is the most recent one, and we all know Miller. So you can say he 17 cases, no AVN with lateral entry nailing in 2012. In summary, infant, child abuse, less than 3 years, child abuse, I will think about it. Less than 1 year, I will actually look for it. I will ask and ask and ask. I will not let it go like this. A child who's not walking, it's very difficult to get a fracture femur. So always remember this. And when he asks you what you're going to do for this, this is an X-ray, blah, 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 blah. My concern here is NAI. First answer. And then the next question after what you're going to do for this, I will do, I have these options. It depends on the child weight. Because I'm concerned also about if there is any skin problems with the traction, gallus traction, or if very, very young, it is like months, I will put Pavlik harness and I'll put spiker. And then take him, and the spiker, I will look at the overlapping. If it is more than 3 centimeters, I would prefer to put a short period of traction, maybe up to 1 week, and then I'll apply my spiker. Otherwise, I will apply my spiker directly. And then he will tell you, okay, next. So if this is how the question goes, okay, what if this X-ray is for a child that's 6 years old? What are you going to do? So my preferred options will be nailing, flexible nailing, unless there is a contraindication for this, or there are problem I'm anticipating in this child. So he told you like what? You can say like if it is more than 50 kilogram, or if there is a concern about the compliance. So what is your other options? So the other options, if 6 years old, still I can put spiker, or I can plate. Okay, and then so we say over here in the summary, if the length is unstable, flexible nail If the length unstable or proximal fracture, yeah, don't forget this. Then it is submuscular plate or rigid lateral entry nail. It's a little bit older. X-fix, protect with bearing after removal, because there is a very high risk of refracture, up to 20%. In rigid nailing, avoid piriformis fossa or turbofurcator trochanter for rigid nails, because we know this 2% and 1.4% respectively. And always warn the parents about the leg length and prolonged limb. These are the two most comprehensive paper you can always quote at the end. This is Cohen Library. It is Intervention for Treating Femoral Shaft Fracture in Children and Adolescents, and this is, of course, a British one, and the American one, it is the AOS guidelines.